Started. First thing is I want Susan Birchfield to call roll.
Okay. Shelley Stevens.
Here.
Karen Beard. Susan Birchfield, that's me. Wayne Dennis. Here. Linda Galvin. Eric Keithley. Jennifer Northway.
Here.
Ram Perez.
Here.
Dr. Chenoy.
Here.
And Paula, we know, is not here.
Right. It is game day. Yes, I saw all of the tents out, the tailgating tents. We have a special presentation to Dr. Chenoy for his service on the Injury Prevention Subcommittee. How many years has it been, Dr. Chenoy? 4 years on the committee. So we have a certificate to present to him and just thanking him for his service. He will be cycling off the committee after this meeting. So we just wanted you to know that we thank you very much for your contributions to injury prevention, and we hope that you're still going to stay involved with recommendations and things like that. Thank you. Okay. Next thing that we have on our agenda is a presentation about the Spectrum of Prevention, which is a strategy tool to help identify strategies for injury and violence prevention. Jennifer Northway, a member of our committee, is going to be doing the presentation. And in some past workday meetings, one of the things that we talked about is, as a committee, is trying to take the opportunity to inform the Injury and Violence Committee or Injury and Violence workforce about tools that are out there. There's a lot of talk about evidence-informed, evidence-based prevention strategies. A lot of times I'll hear people say, well, you talk about that all the time, but tell us what they are. So the Spectrum of Prevention is a tool that was developed by a group out of Oakland, California called the Prevention Institute. Information about this tool is available on their website, which is www.preventioninstitute.org. And Jen's just going to kind of walk us through the tool, and so I'm going to turn it over to her now. About how much time, Jen, do you think you're going to? 30 minutes. Okay. That's fine. I just kind of wanted the group to know. Okay.
Yes. All right. I'm going to steal this, if that's okay. Maybe not. Sorry. Thank God we're not a karaoke first. Okay. Thank you, guys. I was asked to provide this presentation, and it's something that we had presented on at, what was the training that we had held?
TTAF. It was a TTAF
that's
training.
right. That's right. We had participated in a training through TTAF and talked a little bit about the spectrum of injury prevention, and I was asked to present on that again, just for the group. Now, I will give you a little heads up. The presentation won't be as boring as my handout that you picked up, I promise. Can't guarantee any karaoke, but give me an opportunity and I'll belt out in front of the microphone in just a sec. So, as Shelley said, thank you guys so much for being here at 4 o'clock on a Saturday. But I hope you've enjoyed the EMS conference at this point. And I'm very excited to really just talk a little bit about how can you utilize the Spectrum of Prevention model to help with putting together your injury prevention projects in the field. That is one thing that we know that a lot of trauma coordinators have really struggled with. You guys are juggling so many things, so many different items are on your plate, whether it's the PI piece or just having to do pull charge, looking at policies and procedures that your hospital is implementing. And so often it's kind of like, how can I plug in this injury prevention piece into all of the things I'm already juggling? And that's really the purpose of this particular presentation, is to be able to break it down and look at injury prevention in a way that really makes sense and makes it a little bit easier to digest for you, so that as you're out there and you're planning your year, you can pepper in the injury prevention pieces so that it doesn't seem so overwhelming. So let's first talk a little bit about injury prevention. When we're looking at implementing a project, it really is going to follow the same thing if you are a nurse that you're already used to looking at, which is the public health approach. When you're looking at implementing something in your community, you're going to follow that same process of gathering data, defining the problem, developing a plan of action, implementing a plan, and then evaluating and modifying as needed. And as you know, with the nursing process, you're doing that all the time, right? You're just kind of gaining information, you're assessing, you're putting different things into action, and then you're evaluating to see, did I make a difference? Is the patient better? Is there something I need to modify a little bit? And that's basically the same as implementing an injury prevention project or program in your local area. You'll initiate that same process. When we think about the continuum of prevention, there's really 3 ways that you can look at and decide you want to place an intervention in the process. And you might have heard of these things before, especially if you're a certified child passenger safety technician. We talk about pre-event, event interventions, and then post-event interventions. And so basically, you will still look at the same thing. On that continuum of prevention, you could look at something that's a primary intervention, a primary form of prevention, which is a community-based prevention program that is really designed to promote health and safety to prevent injury and illness before it occurs, right? So we know that there's something going on. This is really a true prevention activity. We haven't seen any kind of injury. We haven't seen any kind of illness. Then you have a secondary form of prevention, which really can be a hospital-based emergency medicine or clinical preventative service, where we're detecting or treating problems so they don't get worse. That could include screenings, brief interventions, and referrals. And then the third piece is really the tertiary form of prevention, which is looking at after the event. In the world that we're most used to, that for us is really something focused more on the rehabilitative side, right, or aftercare, which is really aimed at making sure that we can reduce the negative effects of that injury or that illness on that particular person. All right, so the next piece is thinking about, okay, well, we could develop something either pre or during or after. The next thing that you might consider is, well, at what level would I really want to put an intervention in place? And there are really 4 different levels of interventions. So today I should have prefaced my presentation by saying we're really going to be layering some information. So it might sound a little confusing or a little heavy at first, but then we're going to sift it out so it makes a lot more sense when you're thinking about practical application for you in the field. So looking at the different levels of intervention, you can see on your handout that there's really a triangle, and that we're looking at moving down that triangle from something that is most specific at the individual intervention level, moving all the way down to the base of the triangle, looking at population-based interventions, right? So if you really want to focus something at the individual, you're going to select something obviously targeted to that group. If you're looking at something doing organizational, maybe something in your hospital, maybe something with your county, some type of organizational intervention, or a community level of intervention. So it goes individual, organizational, community, and population. And I'm just kind of trying to go through these quickly because this is not the most fun part. So once you decide what kind of audience you're gonna look at, or at what level you're going to implement an intervention, you can look at 4 different interventional methods, which might be educational, behavioral, legislative or enforcement, or looking at an environmental intervention. Here's where things really start to get exciting. Basically, as Shelley mentioned, the spectrum of prevention was something that was developed by Dr. Larry Cohen, and the great thing is it takes all of these things we've just talked about, whether it's pre, post, of a form of prevention, whether it's an intervention focused on the individual, or using a different method, whether it's educational or legislative. He put all of those things into a framework, and that's what we're really going to be talking about, is the spectrum of prevention. It's a framework by which you can look at, okay, what are your resources? What's the problem going on in your community? And really be able to put something together to implement a project in your local community that's going to make a difference based on the different challenges that you're seeing. So let's actually talk about that piece of it so it'll make a little bit more sense. So I need a band, or not a band, but please put it help me with these handouts. And when you look at the spectrum of prevention, you can see that there are 6 areas where we can actually implement a project. Influencing policy and legislation, changing organizational practices, fostering coalitions and networks, educating providers, promoting community education, or strengthening individual knowledge and skills. And so you can see that this framework really includes all of those things. Do you need more? Thank you so much. Sorry I recruited you. You can see that the framework really includes all of the things that we just talked about. Looking at the spectrum of prevention, you know, would we want to do something that's a primary prevention, secondary, tertiary prevention piece? Who's our audience that we want to really engage? What level of intervention might we want to put in place? What kind of method might we use? Well, the nice thing about the spectrum of prevention is it really segregates out how you can implement a project for your local areas, or that we might be able to use as a framework to implement something regionally or even statewide. So I broke this down to be specific to the work that we're doing as it relates to injury prevention being a part of the trauma system. So under influencing policy and legislation, I just wanted to give you guys some examples of how this might help you digest all of that information on injury prevention and thinking about the public health approach and looking at what kind of methods we might use or what kind of population we might assess and actually implement an intervention for, to be able to really have it make more sense for those of us that are lay folks. This really helps lay out for us how we might move forward in implementing a project. And so you can see under influencing policy and legislation, this area for us really is something that we do very well as a group. We'll support injury prevention related legislation, and you guys can be part of that process by either calling or writing your legislator about supporting a specific bill. I know several of you have been very active on coalitions in the past related to supporting legislation, whether it was the Child Passenger Safety Bill or whether it was sobriety checkpoints and ignition interlocks. Participating in lobby day efforts. I know that last session we had tremendous response from this community for lobby day. That's very exciting. And that's exactly the kinds of things that we can do as a group collectively, and it also is an injury prevention effort because we're working together to influence policy and legislation. Another thing that you can do that you'd find underneath that category is to work with legislators to improve existing legislation. I know, again, that many of you are already doing this because being in the field, you see those gaps. You see those loopholes that are often out there and understand that there are times that we need to come together to remove those gaps in legislation, and you're a very vocal group. The reason we wanted to highlight some of this is we don't always often think about these very things as being part of our injury prevention program, and they are. That is helping us create a safer state. It's helping you create a safer local community and a safer region. Another thing, the second step in the spectrum of prevention is looking at changing organizational practices. Some examples of things that we've done as a group would be to support changes to the Texas trauma system structure that improve patient care, support the continuum of care and improve efficiencies, support changes to DSHS operations and or structure related to improving or increasing injury prevention policies and or programs, right? That's part of why this committee exists. Or something that could be done at that particular level would be to implement policies and procedures within your own facility and or an agency that addresses trauma-related injuries. For example, when I was at Methodist Healthcare System and a child passenger safety technician, one of the things I did as an injury prevention initiative for that facility was to look at what were our discharge policies for our mother-baby unit and for our NICU unit. And we were able to actually put in an angle tolerance test policy, and that obviously was going towards our work in injury prevention. The third level in the spectrum of prevention is fostering coalitions and networks. That can be done as an injury prevention project in the field by participating in RAC injury prevention meetings or other injury prevention related community coalitions like Safe Kids. I know a lot of you are already familiar with or involved in those groups. Or maybe a drunk driving prevention coalition. And another thing that you can do as an injury prevention initiative at this level is to recruit other community stakeholders and partners to participate in RAC injury prevention meetings. The fourth level is really looking at how can we educate providers so that they have the information that they need from an injury prevention perspective. One thing that you might be able to do is to coordinate trauma education offerings for staff, physicians, and rehabilitation partners. And the great thing about that is that, as you know, can span the spectrum. And that really allows you some flexibility to look at what's going on in your population and bringing in some specialized educational resources to address that. Promoting community education. You might decide to host a press conference to raise awareness on a particular issue. You might coordinate an educational presentation. I know that one of the facilities that I'd worked with in the past had done a domestic violence presentation for the entire month in the lobby of their hospital as a way to just really raise awareness on the impact of domestic violence in their community. You might decide to organize an awareness event at your facility or in the community. For example, as you guys might know, May is National Trauma Awareness Month, or you could do something like host a bike safety fair. And then moving on to the individual level, the last part of the spectrum of prevention is really focused on strengthening individual knowledge and skills. And some of you are already familiar with doing things in this area. I gave some examples like coordinate a child safety check event in your community or host a skills building class for individuals or families. Now I know this seems very rudimentary, very basic, and really it's meant to be that way. Often what we have found as we're working with folks in the field is that sometimes the injury prevention piece sounds like it's very overwhelming, or it's one more thing that's on a very long list of to-dos, and that it's really difficult to accomplish. But we wanted you to know that there are some community resources available, and we thought if we could break it down very easily, it might make it seem less cumbersome. And so we're going to apply the same model and some of these same activities now to looking at alcohol-related crashes. That continues to be one of the major issues for our state, and of course, since I'm with Mothers Against Drunk Driving, it's something that is near and dear to my heart. But I thought this might be a very good way for us to look at actually applying the spectrum on a specific and particular injury issue. And I wanted you to know that as a committee, we're going to be working to do these for each of the top 5 injury issues that Texas is facing. So the first one that we're going to roll out today is obviously focused on alcohol-related crashes, but we will be putting together similar frameworks for falls, similar frameworks for suicide, domestic violence. We'll be doing some similar frameworks so that as you guys come to these meetings, you'll be leaving with some practical tools, maybe some easier checklists, so that when you go back to your community and you're looking at all the things that you're juggling and thinking about, oh my gosh, I've got to implement an injury prevention piece. And I know we're always talking about, well, is it efficacious? Is it going to be just a waste of my time? Because I know you certainly hear from this committee that we want to make sure that whatever we're doing, because our resources are so strapped, that it is a good use of those resources and ultimately a good use of your time so that it results in behavioral change or change in your community. And so that's the framework that we'll continue to bring to you, is an injury-specific framework that you can take back as you think about planning for the issues that are in your community. Any questions before I move to the alcohol-related piece at this point? No? Okay. Says the spectrum of prevention, and it lists the form that you're getting says spectrum of prevention, and using that framework as it relates to drunk driving crashes. Okay. And let me know if you guys need any. I'm sorry about that. Thank you so much. We were wanting to layer the information so it would make more sense, or I was wanting to layer the information. So the form that you should have in front of you now says the spectrum of prevention. It looks exactly the same as the one we just handed out a little bit ago, but the difference is that it says across the top, using the spectrum to address alcohol-related crashes. And so we kind of broke down within each area or layer of the spectrum of prevention, what were specific activities that rolled up underneath that you could do on a local level to address drunk driving in your community. And so you'll see under influencing policy and legislation, there are things that we've already done as a group, things like support sobriety checkpoint legislation, ignition interlock legislation. There is an example on, oh gosh, tell me what the third piece is, because I handed out all my copies. I can't remember what that one was. Underneath the red. I know this is one I wanted to explain to you guys. One of the things that has recently come out is the no refusal piece, and that was when looking at supporting your county. It says support your county no refusal program. Know that influencing policy and legislation, as you guys know, can really happen on two levels. It can happen on a statewide level and looking at what is our existing policies in place or laws in place to protect our entire state, or what kind of structure does your county have in place, whether it's your county commissioners, related to a particular injury problem. And in this particular case, when we're talking about alcohol-related crashes, unfortunately, there are often other things that are happening on the county level that can contribute to a drunk driving problem, and it's being kind of out of control. For example, one of the things that's listed on there is the opportunity to host a no refusal weekend. Now, some of your communities are already hosting those, and some of your counties are not. Is there anybody who's not familiar with that? Okay, well, just as a quick overview, what a no refusal weekend is with a drunk driving case, this is the only time that we really see when there is a suspected criminal action that sometimes law enforcement is not able to obtain the evidence that they need in order to prosecute a case. So if you have a murder suspect, or if you have any other kind of crime, you're able to secure the evidence from that person. In a drunk driving crash, often you have folks that will simply refuse to participate in a standard field sobriety test by either not getting out of the vehicle or sitting on the ground, or they'll refuse to provide a breath sample. And so often law enforcement is, if they don't have a no refusal program in place, they're not able to actually do anything other than take them to the county jail that night. The person will lose their license for a little bit of time, but they won't be able to truly file charges in some cases on that person for suspicion of DWI. And unfortunately, that has caused a big problem with drunk driving across the state, is that we've got a huge recidivism rate, and a lot of it has to do with not being able to stop the problem in the beginning when we have a suspicion that somebody is driving under the influence. So the no refusal program is fairly new. It's something that's being launched. And so that's just why it's listed as one of the particular pieces as a policy and legislative piece. Another thing that's listed on there, and you might go, why is this listed, is a personal recognizance bond. And I just wanted to explain why that is listed as an example, is that when somebody is released from jail, they often have to pay a bond, and a PR bond or personal recognizance bond is one where they don't have to pay anything. They're able to get out of jail because of their person. And so unfortunately, we do have a lot of areas across the state that are kind of abusing that, and people are allowed to just get out of jail without paying a bond, whereas other folks across the board might be having to pay a bond to actually get out of jail. And I know that probably doesn't understand what, I'm not being very clear on that, but it complicates the issue, because what we have seen when you look from the National Highway Traffic Safety Administration and the 4 E's of traffic safety on the enforcement side, having strict and swift consequences is part of changing behavior related to traffic safety efforts. And obviously, if somebody has to pay money out of their pocketbook to be able to get out of jail, that's part of that swift and strict sanction piece. Sorry, it was kind of a long way to get around it. Changing organizational practices. What are some of the things that maybe you see on there that you hadn't thought about before that might roll up to dealing with drunk driving in your community? Is there anything on there that kind of surprises you? No? One of the things that is a little bit of a challenge, and we're running into this more and more across the state, is because of the no refusal piece, especially in our smaller communities that may not have the resources at their county jail to actually do the blood draws for a no refusal piece, you might be asked more and more often as a hospital facility to turn over a blood draw and any kind of blood evidence. And that is something that I think as a group, we're probably going to need to really have some good discussion on, because unfortunately it's going to be a rising trend. For example, in the Valley, I've got quite a few law enforcement agencies that are often challenged with where can we take them to actually have this blood draw done. In some cases in the state, you can secure a mandatory blood draw, especially in the sense that somebody's been killed or injured in a crash. But if you don't have any place to take them to actually have the blood draw where you could actually secure the evidence, then that presents another problem in the injury prevention process. So that's in there because I think as we continue to grow as a trauma system and grow as a community that's implementing these kinds of programs and projects, you as healthcare providers are going to run into that challenge more and more often. So definitely something that as a RAC you might want to discuss, as a facility you might want to discuss, just kind of developing a plan of how you'll be able to approach those particular issues that come your way. And certainly that is a strategy as well. Fostering coalitions and networks. Obviously in that area you might be very involved with a drunk driving coalition in your community or an underage drinking prevention coalition in your community. I've included, if you don't have any of those coalitions in your group but you're interested in doing something like that, I do have a handout up here on how some effective steps to actually create a coalition, if that's something that you're interested in doing in your local area, to really bring the stakeholders to the table to talk about a particular issue that you're facing and how you guys might be able to collectively address that. Educating providers. One of the things that's listed underneath there is to host a death notification training. That is something that more and more often we're seeing, especially as it relates to traumatic death with drunk driving. So often, as you know, when it's traumatic, people are not often prepared to receive the news that somebody they care for has been killed in a drunk driving crash. Hosting a death notification training is something that your local MAD office can provide for you. So if that is something that you're interested in, please let me know and we would be happy to see what we can do to schedule that to be able to provide you as providers the tips and tools for delivering that information in a compassionate and caring way, considering the circumstances. On the fourth level, or on the fifth level, under promoting community education, again, this might be participating in a Title IX for safety event. It might be supporting a Shattered Dreams event in your particular area. It might be just hosting something in the month of April because it's Alcohol Awareness Month. It could be including, participating in a RAC-wide initiative. These are all things that you guys are already very involved with. And then strengthening individual knowledge and skills. Specifically for you, it could be including something in your discharge instructions. It could be implementing the SBIRT piece in your facility. So there's different ways to really look at, in this particular injury area, what are activities that would fall underneath that spectrum that you could count as working towards your injury prevention projects or your activities. Any questions on that? Okay. And then lastly, I'm going to leave this up here. And one of the things that we have continually talked about as a committee is when we're looking at implementing projects, we're wanting to find out, is it something that's a best practice strategy? So I actually have another handout, and we'll be doing these as well for the other injury categories, as I'd mentioned. And this really kind of overlays those recommendations that are provided to us by the Centers for Disease Control and Injury Prevention and the U.S. Task Force on Community Preventative Services, and looks at what is a recommended strategy, what has insufficient evidence, and what is a completely non-recommended strategy. Now, one of the things that you might see when you look at this particular handout is there are quite a few things that fall underneath the insufficient evidence category. Doesn't necessarily mean that you should immediately stop doing that activity. It means that we need to do more research to determine, is it really a best practice strategy? And so the one that I've brought today, again, kind of overlays on alcohol-related vehicle crashes. And we're looking at influencing policy and legislation. Some of the recommended pieces are things that we either have on board already or something that we're looking at, which is establishing .08 laws, checkpoints, mandatory ignition interlock. Under changing organizational practices, there are not necessarily any recommended strategies at this point. Under fostering coalitions and networks, it is a recommended strategy, but as long as it's coupled with a multi-component intervention with community mobilization, and that's a long way of saying making sure that you've got all the stakeholders at the table and that you're really communicating that injury issue in the community and you're getting the community involved in the process of solving that problem on a local level. And then it breaks it down even further with educating providers, promoting community education, and strengthening individual knowledge and skills. And so these two pieces together, hopefully the best practices strategy piece, as well as the prevention spectrum with the injury-specific recommendations, will help you in determining what's going to be an appropriate intervention to provide in your community as you're getting ready to implement your injury prevention program. So I'm really sorry to give you like this level of information on a 4 o'clock Saturday afternoon, but I appreciate you listening. And is there any questions that you guys might have for me on using this particular framework? No? Okay. Yes. Yes. Good. Good. And I know it's a lot, and I'm sorry, it's hard to kind of just be like, throwing this out there, but hopefully that's the other reason why we color-coded it, to make it a little bit more digestible, so that as you laid out the pieces in front of you, you could just kind of track across the spectrum. So I will I will actually be my own Vanna, and I will distribute the best practice cheat sheets to all of you in the audience. And as I said, we will be having more of these for the other injury topics. And if there's anything in particular that you would like to see, please don't hesitate to let me know. That way, as we craft these, we can respond to your needs. And if there's a particular injury area that you would like for us to craft something first, if you'll let us know, then we can make sure that happens so that you have the tools readily accessible. So thank you, guys.
Thanks, Jen. And I just want to reiterate, too, we're going to be putting this up on going to try and put it on the Injury Prevention Committee's website of DISHS or of GETAC. So this material will be available to everyone. And I also just want to add that if, just like Jennifer said, if there are areas that you would like to see us do first, please let us know, because during the next year, 2012, this committee will be working on developing a spectrum for other injury topic areas and categories. So moving on the agenda, we have a presentation from the Registry Solutions Work Group regarding recommended data elements for the Texas EMS and Trauma Registry.
Just a correction to the agenda. The recommended data element should have been presented last quarter. I'll be, if it's okay with everyone, going on to number 5, presenting the recommended. Oh, sorry. Presenting the recommended reports.
Okay.
Okay. Sorry, we're just going to get the screen up for everyone.
Is it,
Do you know how to get it to project?
I don't, is it not? Is there an IT person in the room for the hotel that could help us with this, or?
That's why I didn't bring mine to put up there. So I'm sorry, you just had me.
That's what Jen told me nowadays. But the previous meeting we had someone
Well, it doesn't even look like, I mean, it looks like it's on there, but, okay.
How'd you do that?
Okay. Thank you.
Good afternoon, everyone. Thank you for allowing me to speak today. My name is Rudy Flores. I am one of the members of the Registry Solutions Work Group, and I'll be presenting to you a stakeholder update pertaining to the building of the new Texas Trauma Registry. What I'll be presenting to you today is the RSWG reports recommended by for the new system. We will quickly review what the RSWG has done to help set up the stage. RSWG has reported the progress being made towards creating a new trauma registry several times at GETAC, and today's presentation will focus on the reports that we've recommended to be available in the new system. We'll provide you information about how you can get more input to dishes about that later on in the presentation. The RSWG purpose was to provide a means for stakeholders to communicate subject matter expertise to DSHS and the ability to interface with other stakeholder groups to ensure that the new registry meets the stakeholders' needs. The formation of the RSWG was a result of the acknowledgement of the importance of stakeholder involvement in the discussions pertaining to the functioning of the trauma registry, and this provides the opportunity to partner with DSHS to work with the specific goals. The RSWG objectives will evolve as the circumstances dictate. As of right now, we have completed several goals. The RSWG did assist with the creation of the request for offer, the RFO, for the new Texas Injury Registry, assist with selecting data elements to be available in the new injury registry, and our current objective right now that we are presenting is the recommended reports for the new injury registry. As the project continues to move along, will continue to serve as a means for stakeholder involvement in the development and operation of the new system. The composition of the RSWG, just to kind of give you some background on the group that's determining all this, is that we do have hospital trauma registrars and trauma coordinators ranging from different trauma designation levels from 1 to 4. We do have EMS, urban and rural involvement. We do have the involvement of GETAC and the Department of State Health Services, Office of EMS and Trauma Systems, as well as the Injury Epidemiology Group. We do have a partnership with TxDOT, who is helping to assist provide funding for the creation of the new system. Nemesis, which is the National EMS Information Systems, which is a system in the National Highway Traffic Administration. We also have some traumatic brain injury, Department of Assistance and Rehabilitative Services, the DARS, and the Health and Human Services Commission, as long as drowning experts, the National Drowning Prevention Alliance entities. So how will the reports be created? As of right now, Consilience, which is the vendor who has been contracted to create the new registry with us, will be building 10 reports that would be determined to be the most complicated reports. In addition to that, the DSHS staff will be trained in how to build these reports. So past the 10 complicated reports, they will be assisting in creating the other reports into the system. In addition, all users who are registered users of the Texas Registry who are using the web portal to go in and build queries will be able to build those queries. And in addition to that, if I'm in Brownsville and I'd like to use a query by someone built in Houston, I'd have the ability to use that query that they built. Just to make sure that I clarify that, I will only be able to see my data. So while I have the option to use that query that was built, I can only see the data that I'm allowed to access, so not anyone else's but my own. And then queries can be created and analyzed with aggregate data that is de-identified for patient and facility based on county, trauma service area, or RAC, or the state. Some of the reports that were reviewed by the RSWG were the current reports that are existing in the Texas CMS Trauma Registry, the NTDB annual report, the NEMSIS annual report, TBI and SCI reports generated by the CDC and some other states, and other reports such as the Trauma Systems Committee reports and reports requested by the RAC Chairs Committee. First of all, we started looking at the current reports that were already in the Texas CMS Trauma Registry. As you can see here, there's the alcohol, the analysis audit, cause of injury, ISS, monthly activity, mortality. These reports will continue to stay in, but just to note that some of the reports may change slightly based on the new data elements that are recommended to be collected in the new system. But we do not have any plans to take these reports out. The current EMS reports are listed, and once again, I do want to emphasize that these may change slightly because of the recommended data elements that are going to be going into the new registry. The RSWG recommendations for report currently available in the registry, we want to keep these current reports so users utilizing them may continue to do so. We want to allow hospitals to run comparison statistics by their trauma designation level. Again, this would be aggregate data and no identifiers to the patient information. We want to allow hospitals to run EMS reports and vice versa for EMS to run hospital reports. Again, aggregate data, and added national data when possible for state and national comparison. So that way we'll be able to, any data element that we use that is collected by the National Trauma Data Bank, we'd be able to compare it to all other facilities who are sending in that information to them. We did look at the NTDB annual report, and this is just giving you an example of it. One of the main types that the RSWG recommends that the NTDB has examples of are comparing hospitals by designation level. We recommend using the same concept for a customer to be able to compare their facility with total aggregate response of other facilities in the same RAC or trauma service area, or compared to the state of Texas. The RSWG recommendations for the NTDB reports. Comparison reports will be available to hospitals only in order to compare compare their hospital with similarly designated trauma centers. Aggregate data used for all data that an authorized user does not have access to view. All data will be de-identified for facilities and patients. And the examples include your hospital compared to other hospitals based on your designation level. Your hospital compared to all hospitals. Aggregate group of facilities are de-identified by TSA or RAC. Disaster response group, hospital bed size, injury rates, and ventilator days. And going into the EMS portion of it, we're going to look at some of the NEMSIS reports that we were able to review as a group. You'll see here that the NEMSIS reports are aggregate and typically displayed such as a pie graph. You do have your pie and your chart on the right-hand side, but you can see that this could be your own data, the data from the RAC, the data from the state, or the national data. So the purpose of having this aggregate data is so that you can see what's going on without having to necessarily know that this is my competition, or that way it's just aggregate data for the purposes. The RSWG recommendations for the NEMSIS reports. Comparison reports will be available to EMS for only a particular EMS to compare themselves to other EMS in their RAC or TSA, for instance. But allow comparison of your EMS firm to your RAC, the RAC across the state or nationally. Hospitals will have access to aggregate EMS reports such as the top 10 patient complaints, and it'll include several NEMSIS reports but enhanced. Some examples of this would be the types of delay, which could be your dispatch, response, scene, transport, or turnaround. And again, mentioned was the top 10 patient complaints is chest pain, breathing problems, trauma, and et cetera. As you recall, the RSWG recommended enhanced data elements for TBI and SCI, and if we wanted to also show an example of a report focused on just these conditions. So you can see here where you'll be able to compare your RACs, the state, and to the entity reporting. The RSWG recommendations for TBI and SCI compare the data between facility, TSA, the Trauma Service Area, Iraq, and the state and the national elements. This will also help for the facilities or agencies' use of benchmarking information. The information will still be aggregate data. It'll allow for comparison of data. Some examples would be your facility compared to all other facilities, the cause of TBI or SCI, whether it was work-related, or the TBI and SCI by the hospital trauma designation level. The RSWG did evaluate some of the reports that were currently being sent in by the GETAC committees. This is a report that was actually requested by, I believe, the RAC Chairs and Trauma Systems Committee. Here you can tell that these, on the left-hand side, your table 3, the 4 most frequent non-fatal injury E-codes, and then the top 5 non-fatal injury categories. Another recommended report by the RAC Chairs Committee. This will also show you that it's being compared to your entity, the RAC, and your across the state. And another one of transfers to a higher level, no transfer, lower levels, and out of your RAC. And that goes by entity, RAC, and state. And I'm sorry, that one did not go into color. The RSWG recommendations for other reports. Annual reports for EMS, hospital, RAC. Some examples would be the Trauma Systems Committee report, which provides an overview of trauma in Texas for the year for each RAC. Stakeholder requested reports, the Office of EMS and Trauma Systems RAC Chair Survey. We asked the RAC chairs for suggestions and received ideas not currently in the system, such as method of payment, transfers, and farm and ranch injuries. The RSWG and DSHS has been listening to the interests of our stakeholders and are committed to creating additional reports to help them with their work. Standard reports and reports from the RAC Chair Survey is part of our effort to put their ideas into the system. Our next steps for the RSWG. Many reports have been in the beginning of development, but it is still an ongoing process. DSHS will seek stakeholder input from injury prevention coordinators and drowning experts. That will be on a call organized by the Office of Injury Surveillance and Epidemiology. DSHS will also offer webinars to seek more stakeholder input for types of needs and reports. Those webinars are scheduled to be taking place on November 29th and November 30th. Resulting FAQ from the webinars will be created and posted to the DSHS Injury website. Email notifications will inform the stakeholders of the dates and times of the webinars, how to register for the webinar, and the location of the documents and how to provide their feedback from the webinar. If you have any questions about that, you can contact Tammy Sajak, which is the manager of the Injury and Epidemiology Group, with her information provided above. Is there any questions?
Thank you. Any questions from the committee? Any questions from the audience regarding the report?
Thank you.
Okay, thank you. Okay, next thing on the agenda is a discussion of possible workday meetings for the Injury Prevention Committee. Previously, we have scheduled workday meetings because we've had a lot of work to do and couldn't get everything accomplished during just the regularly scheduled meetings. So we've scheduled workday meetings during 2011, the month prior to a regularly scheduled GETAC meeting. So I'm going to ask the committee, are you interested in doing that next year? One of the things that I think the committee needs to work on, in addition, and will fall into with the work on the spectrum of prevention, is doing some strategic planning, which we have also talked to TTAF and the trauma coordinators about engaging them in the strategic planning, and have had very positive feedback about that. Group, are you interested in workday meetings?
Yes, I think the workday meetings have been very useful, and I would like to see them continue.
Okay. So are you, please do.
Okay. I'd like to make a motion that we do consider developing a schedule for workday meetings in 2012.
Okay, Jen, what, okay.
And then I guess my question to you is, do you want us to, sorry to do a sidebar here, but do you want us to request a specific date to vote on, or just?
Actually, I was thinking, I think what we've done, and maybe we could throw this out, is the last Friday of the month prior to the regularly scheduled meetings, which would be January 27th, April 27th, July
January 27th, April what?
27th, July 27th, and October 26th.
How funny is that?
I know. Next year is a leap year.
27, 27, 27. Okay, then I might amend my motion. I can't amend my motion? Okay. Yeah, I'd like to amend my motion to.
Okay.
I'd like to make a motion that we host our injury prevention workday committee meetings prior to the actual GETAC committee meeting. And I propose to host those on January 27th, April 27th, July 27th, and October 26th.
Susan, do you amend your second? Yes. Okay. Any discussion from the
Just
group?
repeat those dates again.
I beg your pardon?
Repeat those dates again. January.
Repeat the dates.
January 27th, April 27th, July 27th, and October 26th.
Dr. Shinoy?
Where will the location of these meetings be?
That will be the second thing we decide after this. So let's, any other discussion regarding, all in favor, say aye.
Aye.
All opposed? Okay, the other thing that we tried to do in 2011 is potentially have spread it out across the state so that we're not just always meeting in Austin. So I know the July and October meetings for 2011 were canceled, but what...
The only recommendation I would have is don't come to well, maybe. I say don't come to San Antonio in April only because of Fiesta. So.
Which is
But
what
we'd
we
be
did
happy-
last year.
Yes, right. But I would be happy to host in San Antonio if that works for the group, and if we feel like moving those across. I know this is kind of out of order, but is it possible on this one to take comment from the public to see if this would increase their ability to actually participate in one of our workday meetings as a committee?
Did you all hear that?
Okay, sorry.
We have set dates for workday meetings for 2012. The discussion now is where to hold those meetings. In the past, most of the time, it's always been in Austin. In 2011, we talked about trying to spread it out to other parts of the state, just so that everybody wasn't always having to travel to Austin. Jen's question was if she'd like to see feedback from the audience. Does us scheduling meeting locations have any impact on the audience ability to participate in those workday meetings? And those workday meetings are open, so it's a time for the committee to get some work done, but it's also open to the public.
Yes. So if we moved those around, would you be more inclined to participate, or would we still be just like dreaming that we would have other participants? No? Y'all would? by show of hands, if moving them around to other areas that would make it more, it would make it easier for you to participate. Okay, well, I saw a few.
Okay?
Of course, of course. Well, I'm happy to host in San Antonio.
I'll be happy to host in the Temple area.
Okay.
And I would be happy to host in the Dallas area.
And then I guess we could
Maybe
do
one
in-
Austin?
One in Austin. So,
Okay.
then I would make a motion. Now, do you want me to automatically assign? Do we need to talk about, before we make that motion, do you want to discuss? which-
Well, we might think about not doing San Antonio in April,
That would be
or San Antonio in July, just for. I beg your pardon? Okay.
She's able to host in Tyler.
It's getting further and further for me.
Okay, so do we have 5 locations now, Jen, or 4?
We have 5 locations.
Okay.
Um,
Well, then I can take Dallas off.
I think yeah, I would keep Dallas.
Okay.
Keep Dallas. Sorry, can't back out on that one. No, I'd keep Dallas. And I would keep, I guess by show of hands, is that okay?
That's fine.
By show of hands, who would want one of the workday meetings in Austin? Okay. Who would want one of the workday meetings in San Antonio? Oh, more hands on that one. Sweet. Okay. Who would want, I'm just kidding. Who would want a workday meeting in Temple? Okay. What about Tyler? Yeah, you're like, please, 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 right? Okay. Okay, what about Dallas? Who would want a meeting in Dallas? Okay. So Dallas wins for sure.
What I might suggest, Jen, is okay, we probably do need to select locations.
I don't know how you want to do that.
Okay.
This is your bright idea.
Do I hear a motion for, from the group?
Just
Ram?
a comment. As far as Temple and Tyler, love to go there, but it's getting further and further away for me. And there's no
Okay.
airport access.
Okay. Dr. Shinoy?
I think Austin should be one, at least one.
I think so
work,
too.
Okay.
Austin should be at least one of the locations on a regular basis.
And Ram's comment was that Temple and Tyler are getting further away from him, just for, and for the folks who have to travel from more remote locations without major airport access.
Sure.
Okay.
Do what?
I need probably a motion.
Do we have a
with-
partner in Houston that might be able to, I mean, I hate to throw that out there, but then we could do, then you could do Dallas, Austin, Houston, and San Antonio. Would that be and that would be accessible for people to fly? Would that be okay?
Does Dallas, Austin, Houston, and San Antonio sound good?
Does that sound better to the
Is that
group?
good?
I
Okay.
think that's good, yeah.
Okay, I need a motion.
Okay, well then I motion to host those meetings in Dallas, Austin, San Antonio, and Houston.
Okay, do I hear a second?
I second it.
Dr. Shinoy seconds. Any discussion? All in favor of those cities for workday meetings, say aye.
Aye.
All opposed?
Oh, we have an opposed?
What-
He's opposed.
He's opposed?
Yes.
Okay. Did you get that? Okay.
Wayne hates.
Sorry, Wayne. Okay, I think item number 5 on the agenda is probably just my mistake. I put the Registry Solutions Work Group on there twice. I want to open it up for public comment from the group. And if you have a comment, please step to the microphone.
I have a question for the work group. When is the likely date of starting the rollout, of the
August 2013.
August 2013? Okay,
Rollout for the new registry.
okay.
I'm sorry, 12.
Okay. Would it be done in a stepwise fashion, or would all the components be available right at the outset?
Yeah, let me try to answer that. Can you guys, this is on, right? I'm Tammy Sajak. Some of you guys have met me before. I'm the manager at DSHS who has the injury program. So to give you a little update on that, I did give an update at the Texas Trauma Coordinators Forum yesterday. I'll try to be as succinct as possible, but there are a lot of details. We have all of the question packages have been built into the system. And so that's for TBI, SCI, trauma, from hospitals, EMS, all of the different runs, medical runs as well as trauma runs, and submersions will also be electronically reported through the new system. And we had to wait. We've had those questions in there since this summer. And then we had to wait a little while for NEMSIS, which is the EMS data elements, to get final. They got finalized November 1st. We went back in and made about 400 changes based on the final data elements, because it's a very large data set. And what we're doing is we're having all of the NEMSIS data elements available in the system, every single one of them. So if somebody wants to report every single one of them, they're there. We're having every NTDB data element also available in the system. But the Registry Solution Work Group has made recommendations about which one of those they think everybody should report. And so those presentations have already been given. Doesn't mean we won't go over that again, but they are available on the DSHS website. So what we while we were waiting for the NEMSIS data elements to get finalized, we started working with the Registry Solution Work Group on the reports that we wanted to build in the system. You can't build reports and you can't migrate your legacy data over until your questions are final. Otherwise, you have to change the reports you built and you have to change the data that you migrated, which basically means do it over again. So we've been cleaning up our data, our legacy data, and we've given this in stakeholder presentations, not only at GETAC, but in other webinars that I've held. And you can sign up for those webinars on our website. And you can sign up for the next two that are coming up on the 29th and the 30th on our website as well. But what we're going to migrate over into the new system are only the data elements that we have complete data on that are really useful for you running a report on. There's no sense in moving a bunch of optional data over to the new system that is incomplete and that you can't run a report on. So what we're going to do on November 29th and the 30th is show you the question packages. They're not in a user format that you will see when you come into our system to use it. What you're seeing is what's behind the velvet curtain. It's what we see structurally, but we'll walk you through it just so that you're able to see that we really are building something and that we really have been getting a lot of work done. So the next thing that will happen now that we finally have the NEMSIS data elements finalized is that probably by the end of December, beginning of January, the legacy data will be migrated over, and then we will work with Constellians to identify what the 10 most complicated reports are, which right now, for instance, one of those will be rates. Right now you haven't been able to do that in our system, but we want to have some population data in there so that you can generate some rates which are very useful to people besides just knowing numbers and percents. We are also getting ready to kick off proposed rule changes. So there's going to be a lot of activity with DSHS working with the Registry Solution Work Group on whatever your ideas are for how you would like to see any of those rules changed. We're working very closely with the Office of EMS and Trauma Services on this because their rules are interrelated with our rules. So as we move along, some of the key stakeholders who are in RSWG are going to be given guest pass so that they can go at any time and look at the system that we're building. They won't be able to access confidential data. We're going to put some fake data in there that can be played around with to run some reports on. Then we will continue to do the webinars, and as that system has its interfaces built so that you would see potentially what it would look like, then we'll start doing usability testing. So we'll ask you to come in and click around and tell us what if you found links that didn't work, if things are inconveniently located and you would like to see them another way. And then some other pieces that haven't been built that we have just been negotiating some new business requirements with Consilience on is for you to be able to manage your own account better, and for people who don't have accounts to be able to come in and create an account. We realize the way that that happens right now is very awkward. You download a form, you fill out a form, you fax that form back to us, we enter it in, then you get a password and you get access to the system. Some things you can administratively change and some things you can't. So we're trying to increase your ability to be able to request changes to your administrative data for your hospital or your EMS firm, as well as being able to come in and sign up to the system. We're expecting to have many more users in the system because we're broadening the scope of people reporting who have already been in the law that they should report, but who we haven't traditionally actively pursued. Medical examiners, justice of the peace, to name a couple of them. We also know that different people in hospitals report submersions, drownings, and near drownings, so they'll be coming in as users. We're hoping to get some post-acute rehabilitative data in there. They'll come in as users. We're hoping to get all the prevention coordinators signed up on the account of the facility that they work at so that they can come in and use the system. So we really are expecting a lot of users, so we're building a place where you can come in to get your account registered that ought to be more straightforward than what it is right now. We also had to go back and change some of the requirements about linking data because the way our system is set up is different than a lot of other systems. A lot of other systems would have, let's say, DSHS employees around the state. Well, they would be able to see all the data in there, so there would be one table for the patients. But you all are different, and we have different needs. So you can't see another facility's information. Well, that creates a lot of complication when we want to link EMS and hospital records together because we don't have just one big patient table in there. So we have told them this is a very top priority of ours to be able to link these EMS and hospital event together for individuals, and they've come up with a way to do it, and we just went over that last week. So we will be creating data analysis files that have the de-identified patients over time for their whole event, and we'll be able to do a lot more with that. So that's kind of the overall plan for the registry. We are still on time. We so far don't have any delay. What we've done is there are certain things that can be built after we go live because we don't have a need to be able to extract data out of the system until we get some into it. So they can allow you to enter data in August, and then we can have the extracts built, for instance, in September, so that people who need to extract data to send to NTDB can do that, for instance. What else am I forgetting? Vendors are really, anxious to see when they're going to have the file layout, and I'm thinking that that's probably going to be around January to February, because not only do they have to know what the data elements are and how they're formatted, they have to know the file specifications for the extract, the format that we want the extract in, and some other technical stuff about how it gets into our system. And Consilience has to create that, so that'll be a little later. We already know the data elements, but I'm thinking around end of January, I'll start having some conference calls for vendors. What else am I forgetting? Any questions? I think that's all I can think of right now about how to build this system. Any other questions from y'all? Okay.
Thank you.
Thanks, Tammy.
Thank you, Tammy.
Okay, any other announcements from the committee?
Yes.
Jen?
Yes. This last week, and for those of you who don't know me, my name is Jennifer Northway, and I'm the executive director for Mothers Against Drunk Driving, the South Texas affiliate. And I just wanted to, update all of you. This last week, we held a rally here in Austin to announce the 5th anniversary of our campaign to eliminate drunk driving. And as we prepared for looking at what kind of progress we've really made in the state, I thought it was important to know that I was really disappointed by the data that I saw. And I know a lot of us have been working on this issue, and it kind of comes up again and again when folks are like, well, we're already doing something for drunk driving. Like, why are we still doing something for drunk driving? We need to do something for car seats or bike safety, or we need to look at falls, or we need to look at suicide, or various and sundry other injury issues. But what was most disappointing to me as we were preparing for that report is to look at the fatality data from 1999, which showed that we had a little over 1,800 people killed in Texas from alcohol-related crashes. And then fast forward to looking at 2009 data, we had a little over 1,400 people die on our roadways here in Texas related to drunk driving. And I was really disappointed to see that we had only, looking over that significant time frame, that we have only really dropped by 400 people. And so that was just something that was really kind of startling to me. And honestly, obviously this is kind of the focus of our work, but for me it really helped me to refocus and think about, okay, what can we do to really focus our efforts and make sure that the things that we are doing are really going to work and they're going to change behavior. And I think that's also kind of what spurred the renewal of the presentation, and then looking at the spectrum of prevention and how can we overlay that to the work that we're doing on a day-to-day basis, both for you as injury prevention professionals and those in the trauma world, as well as us as community members and providers. And anyway, I thought it was interesting. If you're interested in our report to the nation, we did deliver a report to the nation on our progress related to drunk driving prevention. We looked at every state in the country and 5 different areas. We looked at whether or not they had something related to child endangerment, something related to automatic license revocation, whether they had a no refusal program in their community, whether they had a sobriety checkpoint legislation, and whether they had ignition interlock legislation. And unfortunately for Texas, we don't have sobriety checkpoints or mandatory ignition interlock legislation. And so Texas was awarded a 3-star rating, so we certainly have lots of work to do. And you might say, well, why sobriety checkpoints and ignition interlocks? Combined, they have been shown to be some of the most impactful in actually driving down the numbers. And ultimately, that's what we want to accomplish, just like you do. Reduce the deaths, reduce the injuries. And so if you're interested in learning more about that report or learning about about what you can do to get involved with that, certainly check that out on our website, which is at mad.org. And I'd be happy to talk with you further, because I think certainly I'm going to ask this committee to continue to help us as we prepare for the next session, as we look at what's going on across the state. We have far too many people dying on our roadways for something that's so preventable. And we know what we can do to make it better. We know what we can do to make sure that folks can live to their full potential. And I know that you have that at the heart of your work as well. So, sorry.
Thanks, Jen.
And just one more comment. I apologize for my voice, but a national committee has started a co-sleeping campaign, and it's been on the national news here lately, so I think we should watch that closely so that we can further project that in Texas.
Okay. Other announcements? Okay, our next meeting date will be, and I'm going to go ahead and read out the dates again for the workday meetings and the locations that we've selected. We will be, I will be talking to the folks within TTAF and TTCF about joining us on those dates. We will be spending the bulk of those workday meetings developing a strategic plan for injury and violence prevention for Texas. We will also be, Tammy's group will be providing data to us on a quarterly basis, and I might add that the first piece of data that they've provided is on motor vehicle crashes, and they have reports for each TSA, and just thumbing through this, we're going to make this available on the website as well. But they've done some really good analysis. They're looking at it by age group, sex, race, ethnicity, looking at trends over time. And again, this is for each TSA, so I think this is going to be very valuable information for us as we continue our planning and going forward. Our workday meetings will be January 27th in Houston, April 27th in Austin, July 27th in San Antonio, and October 26th in Dallas. And then the regular meetings will be February, May, August, and November for the regular GETAC meetings. And if there are no other comments, questions, we will adjourn. Okay, sorry. Can I hear a motion to adjourn? Gotcha. Second? All in favor? Okay. I'll get that.